It's a great pleasure for me to introduce Professor Barbara Casadei, who is the current president of European Cardiac Society. Professor Casadei, among all the other very important inputs in cardiology, she has a remarkable research work on investigating the substrate of several cardiac diseases, such as atrial fibrillation. So I couldn't imagine more appropriate person to talk about atrial myopathy in atrial fibrillation and give us her view on who is really at risk for stroke in this disease. So, Professor, you can start, and we are ready to enjoy your lecture.
Good afternoon, ladies and gentlemen, and thank you for inviting me to the 41st Panhellenic Congress of Cardiology. And I've been given a title that really looks at the link between the risk of stroke, cardiomyopathy, and atrial fibrillation. So here are my disclosures. So why do we think it is important to discuss this, and why we think that the current approaches of risk evaluation may be inadequate? Well, we know that they are quite imprecise. And also we know that we are grouping under atrial fibrillation possibly a number of diseases, and that is that atrial fibrillation is a syndrome, essentially. And all of these different diseases may require different therapeutic approaches and also may have a different stroke risk. So we believe, therefore, that a better understanding of these mechanisms may lead to better targeted and efficacious therapeutic strategies, and this include better targeting of anticoagulation. So why are we going on and on these atrial cardiomyopathies? What do we have in our hands that might tell us that this is actually an important feature of atrial fibrillation and embolic stroke? Well, we know, and we know this for a while, that there is a not quite such a precise relationship between episodes of atrial fibrillation and thromboembolic events. And the first work to highlight that was the ASSERT-1 studies. And in these studies, the relationship between high heart rate episode detected by an implanted device and a thromboembolic event was not as expected. In fact, about 31% of these atrial episodes occurred after a stroke, so they couldn't be thought to be causally related to that stroke. 15% only occurred within 30 days of the stroke, and 54% occur more than 30 days with a median of 6 months before the stroke. So, you know, it's not so clear that atrial fibrillation may actually cause an environment in the atrium that leads to stroke, rather than that the environment is already there and atrial fibrillation is a consequence of that. Another piece of information that casts some doubts on our sort of view of atrial fibrillation and embolic stroke were the results of the COMPASS trial that was presented at the EFC meeting a few years back now. And what this study shows that is essentially that individual with a high CHA2DS2-VASc risk, but no atrial fibrillation or no clinical atrial fibrillation, seems to have a high risk of stroke, and this risk of stroke is reduced by treatment with direct anticoagulants, with or without aspirin. So, you know, atrial fibrillation, if the risk is high, is not needed to benefit from anticoagulation, according to this study. So, given this background, what can we learn really from either genetics or imaging that might illustrate a bit better? So genetics has been indirectly useful because recently a number of variants, rare variants, in either structural or sarcomeric protein have identified both a high risk of atrial fibrillation and a high and premature risk of stroke. So here is an indication that not an ion channel problem, but a structural problem, a problem of contractile protein, might then affect the risk of atrial fibrillation and stroke. And in fact, these data cumulatively may be seen as indicating that atrial fibrillation is a biomarker of a cardiomyopathy that causes both atrial fibrillation and the increase in stroke. So what about for imaging? Well, we've known for a number of years that a dilated atrium is associated with an increased risk of stroke, but particularly in patients in sinus rhythm, not so much in atrial fibrillation. And more recently, we have refined these measurements. And for instance, in patients with atrial fibrillation, we know that the amount of fibrosis as measured by late gadolinium imaging of the atria, as shown here, is associated with an increased risk of major adverse cardio and cerebrovascular events. And so this is in the context of atrial fibrillation already. And points towards a dysfunction of the atrium. Even more compelling are the results of the MESA cohort. Here we have 4,261 individuals who were recruited at around the age of 60 without cardiovascular disease and followed up for about 12 years. And if, when the authors looked at the left atrial emptying fraction, so a measurement of function of the left atrial, so they saw that a lower atrial emptying fraction is associated with a worse stroke and TAA-free survival. So here is an indication that functional abnormalities of the left atrium can lead to ischemic stroke even without atrial fibrillation. Now, and this is how this measurement would help the C statistics in terms of stroke prediction. So now these are all somewhat indirect measurements of what we really want to know, because what is it that is actually causing a thrombus in a cavity? And we know for many years now that the Virchow triad are the most important risk factors for thrombus formation. And those involve endothelial dysfunction, which is difficult to measure in the left atrium, hypercoagulable state, which has been advocated in atrial fibrillation, but principally a blood flow abnormality or a stasis within the left atrium. So if we could measure blood flow dynamics within the left atrium, would we actually reach a better prediction? And now this is possible, again, using advanced magnetic resonance imaging. And this is Dr. Marcos Partero, who's working in Oxford on this project. And he has imaged the flow inside the left atrium, in this case of patients with very low stroke risk and in sinus rhythm. And you can see this beautiful vortex that is forming within the left atrium at each during filling. And I didn't know that this was happening, and I went on to look at the history of vortices in medicine, and apparently they are common and they are very important. For instance, we know that optimal vortex formation in the left ventricle is an index of cardiac health. And if you have this index, you can easily discriminate between a cohort of patients with normal left ventricular function and those who have dilatation and cardiomyopathic process just by looking at vorticity. Then we also know that the vortex behavior is associated with thrombus formation. Essentially, this movement helps washing all the walls of a cavity, being that the left atrium of the left ventricle, and to stimulate shear stress, nitric oxide formation, and inhibit platelet aggregation. And here is again what happens in the ventricle, where in normal hearts you have a vortex that fills in the whole ventricle and touches all the wall. And in dilated cardiomyopathy, you have areas of the walls that are not remotely touched by this movement and therefore become very prone to thrombus formation. So what happens in the atrium and what happens in atrial fibrillation? Well, here you can see what happens in atrial fibrillation, and this is a very different picture for that. Everything is slower. There are big holes. The vortex does not cover the whole walls, does not touch the whole wall in the same way. And so, you know, you can easily understand why this is a prothrombotic situation. What happens if then you take the same patients, you cardiovert them into sinus rhythm, and you find that again, the vortex is back, but it's not quite as fast and not quite as dynamic as the one that we see in normal subjects with no risk factors. Here we have also risk factors. But is this atrial fibrillation or are these risk factors? And so to look at that, we compare with patients with in sinus rhythm that have the same risk factors. And it's essentially this kind of impaired pattern of flow is not distinguishable between the two. So here we have evidence of prothrombotic flow even after recovery of sinus rhythm in patients with high risk of stroke, virtual Charles-Vass score, that also have the same slowing and characteristics. So these are the average data that demonstrate that. Both are similar and both are very different from normal. So is this got anything to do with stroke? And the follow-up of this study indeed shows that vorticity is associated with stroke, and that patients who had an embolic or large brain infarct are those that seem to have an altered pattern of flow versus patients who had a brain infarct, but maybe a lacuna or a small brain infarct or no brain infarct at all, where we still see this vorticity, a better vorticity pattern. So it becomes discriminating between these two categories. So is it just an atrial problem or is it a whole cardiac problem? Of course, if we only look at the atrium, we will come to the conclusion that is an atrial myopathy. But actually, we can see that not so much the systolic function, but the diastolic function here is very much associated with these altered patterns in the atrium. So suggesting that the involvement here is not only of the atrial myocardium and may be even a consequence of a primary, perhaps, disturbance of the ventricle, and particularly the type that would lead you to a heart failure syndrome with a so-called preserved ejection fraction. And indeed, a few years ago, we did look at myocardial energetics and perfusion in hearts of patients with lone atrial fibrillation. In fact, most of them were paroxysmal, so not so severe in that respect, with a left ventricular ejection fraction still within the normal range. But even in these patients, we could see a subtle alteration of the energetic as measured by the phosphocreatine to ATP ratio. You could see that compares to control in sinus rhythm, the ratio is reduced, and you can also see that it doesn't recover post-ablation. So the fact that 6 months of sinus rhythm or more does not reverse this abnormality, suggesting that this abnormality is there to start with. And the same is also the case for myocardial blood flow, which is also impaired compared with control and not really reversed by recovery of sinus rhythm. So essentially what I'm proposing is that there is a continuum of cardiomyopathy that involves both the left ventricular diastolic dysfunction, left atrial dysfunction, and then they can really, the higher risk culminates with the presence of all of this plus atrial fibrillation that changes all the patterns of flow and the blood velocity within the atrium over and above what we see before. So, along this line, the risk of stroke increases, and each of these parameters may help you classifying the stroke risk in patients. So in conclusion, I would say that the relationship between atrial fibrillation and stroke is part of this continuum of a cardiomyopathic process, probably due to a long-term exposure to both environmental and gene factors. In that a cardiomyopathic process that involves both the ventricles and the left atrium may underpin both the risk of atrial fibrillation and the risk of stroke, both together and independently. So my optimistic prediction is that advances in genetics and imaging techniques and also the availability of large biobank and cohorts, which would allow their applicability at scale, will provide much needed breakthrough really on refining risk stratification, the taxonomy of atrial fibrillation, and also refine the treatment strategy of both atrial fibrillation and cardioembolic stroke. Thank you very much for your attention.
Professor, for this
Good afternoon, ladies and gentlemen.
Overview and explanation, I would say, of all this process of atrial myopathy during or without atrial fibrillation. Actually, I thought that you gave many answers on this timing discrepancy, I would say, between stroke and atrial fibrillation that we can see in several trials, where we can see that the event is very remote from the actual event of atrial fibrillation. My question is, how close do you think that we are in introducing a sort of CHA2DS2-VASc score in individual of not having atrial fibrillation, I mean, to introduce anticoagulation?
Well, according to the COMPASS trial, we are already there in some respect. I mean, they didn't calculate the CHA2DS2-VASc score in these patients, but from the risks and the pre-existing cardiac disease, you can already find out that it is high. So we already have evidence that treatment with anticoagulation, with or without aspirins in these patients, prevents ischemic stroke and prevents ischemic stroke more than it prevents myocardial infarction, for instance. So there is already at least one trial out there that would support the use of anticoagulation in high-risk patients.
All right.
Make a comment, Nikos.
Professor Gatzoulis, he would like to.
Professor Casadei, excellent talk. Thank you very much for joining us. I enjoyed the idea of not having only atrial myopathy, but also ventricular myopathy in patients with atrial fibrillation. And this might explain a lot of points like the following ones. There is an associated sudden cardiac death rate in patients having had atrial fibrillation. There is also an associated risk of mortality in patients with atrial fibrillation, apart from the stroke risk. We have found that there are also commonly found late potentials on signal average ECG of ventricular myocardium among patients with atrial fibrillation. There are a lot of atrial fibrillation guys who have a lot of PVCs, although they have normal left ventricular ejection fraction on echocardiography. So there is a lot of evidence that there is an associated involvement of ventricular myocardium. Thank you.
Yes, no, I agree, particularly as the predominant cause of death in patients with atrial fibrillation is cardiac, is not stroke. I mean, stroke contributes importantly, but it is comparatively a minor cause of death if compared with any cardiac causes, including arrhythmias of any kind, sudden cardiac death in particular, and also sinoatrial node disease. So, absolutely.
Okay, I would like to thank Professor Casadei for this excellent talk, and we can continue with Professor Gatzoulis. Thank you again.
Thank you. Bye-bye.